Hello everyone, this part we go on talking about the diagnostic procedure. After confirming the diagnosis, then we assess the severity and determine the causative pathogen. Assessing severity, we usually use the Cober-65 scale. C is confusion, U is urea, R is the respiratory rate, B is blood pressure. 65 is age. Give 1 point of each feature present. Score 0 to 1 point is low severity and can be treated at home. Score 2 points is moderate and should be treated in hospital. If 3 to 5 points is severe and should be assessed for ICU admission. As the score increases, the mortality increases. If a patient gets 5 points, the mortality is up to 57%. According to the IDSA-ATS guidelines, direct admission to the ICU is essential for patients with septic shock requiring vasopressor or respiratory failure requiring intubation and mechanical ventilation. ICU admission should also be considered for patients who have 3 or more of the following, such as confusion, uremia, hypotension, or multi-lobe infiltrates, and so on. Next is determining the causative pathogen. This relies on the laboratory test. We can send the sputum for gram stain and culture. A qualified sputum sample must have more than 25 neutrophils and less than 10 squamous epithelial cells per large pore field. The sensitivity and specificity of the sputum, gram stain, and culture are highly variable. Even in cases of proven bacteremic pneumococcal infection, the yield of positive cultures from sputum samples is less than 50%. For patients admitted to the ICU and intubated, a deep suction aspirate or BALF sample has a high yield on culture. We can also do the pre-antibiotic blood cultures. Because the yield is so low, only 5 to 15%, so it's no longer considered for all hospitalized CEP patients, but is strongly indicated for severe CEP patients and host factors like cirrhosis, splenic complement deficiencies, and leukopenia. By the way, blood cultures should be collected bilaterally and both for anaerobes and aerobes. Urinary antigen test is only available for Streptococcus pneumonia and Legionella pneumophila serogroup 1. The sensitivity and specificity is very high in adults. It's rapid, simple, and can detect antigen even after initiation of appropriate antibiotic therapy. The disadvantage is the false positive from pneumococcus colonized children, and Legionella pneumophila is only for serogroup 1. For the atypical pathogens such as chlamydia pneumonia, mycoplasma, Legionella, a 4-fold rise in specific IgM antibody titer between acute and convalescent phase is helpful for causative diagnosis, but is not practical given the slow turnaround. It's more useful in retrospective analysis. Hospitalized patients with severe respiratory illness without other explanation and suggestive of infectious etiology should be get screened for influenza during season. Nasopharyngeal swab or nasal wash or aspirate can be collected. Rapid flu test only need 15 minutes can distinguish A versus B type. Furthermore, respiratory virus PCR panel can detect more viruses. Let's end this part with a case. A 35-year-old male experienced fever, chills, cough with rusty sputum, and headache for 4 days. Physical examination showed high temperature and hypotension. Artery blood gas analysis revealed respiratory failure. Blood tests showed increased white blood cells and decreased platelet. Procalcitonin and CRP increased dramatically. For this patient, the blood culture came out with Streptococcus pneumonia. The urinary antigen for Streptococcus pneumonia is also positive. So for this patient, the causative pathogen is clear. So, thank you.